Good evening and welcome everyone to our 1-hour webinar this evening entitled Providing Resources for a New and Better Normal in Patient-Centered Dental Care. This webinar is co-sponsored by both the University of Utah School of Dentistry and the Utah Dental Association. My name is Gerald Bozeman, and among other things, I'm the Director of Continuing Education here at the U of U, and it is my pleasure to be your host this evening. As we're all aware, the response that we had to COVID-19 starting a few months ago caused the closure of all non-essential business, and with social distancing for the last several months, we're now excited and all trying to get back to work, but we're struggling to figure out the best and safest ways to do so. COVID-19 is a relatively new virus. We learn more about it every day, and we're receiving recommendations from various entities as this knowledge evolves. Some of it is confusing and some of it is even conflicting, making it difficult to know if there is one authoritative source. Often we are left to our own best judgment to determine best practices for our own situations. We hope that our presentation tonight and the discussion here will give each of you information and ideas to help us all return to the business of serving our patients while keeping everyone safe as possible. We have 3 objectives. I'll just review those quickly. The first objective is to gain a better understanding of safety during the COVID-19 pandemic. The second is to learn about the ADA and CDC guidelines. And the third is to learn how to better communicate with patients to inform and increase their comfort in our dental offices. It will be a 1-hour webinar. We will have 3 presenters, and we're allowing a little bit of time at the end for questions. So during the webinar, if you have questions, please submit those online using the Q&A feature. Don't use the chat feature for this. And you'll receive 1 hour of CE credit by logging in and attending. We'll talk about that at the end. If you have technical difficulties during this, there's a number you can reach. Jot this down just in case you get cut off. That would be 801-243-1481. And I'd like to now introduce our 3 speakers. The first being Dr. James Bekker. He is an associate professor here at the U of U School of Dentistry. He's also the assistant dean for external clinic partnerships. And he is by training a pediatric dentist and has practiced for a number of years. Can I say decades, Jim? In Sandy. So he will be our first presenter. Our second one is Dr. Jeri Bullock, who is an assistant professor here at the School of Dentistry. She is the dental director of the South Main Clinic. She's also co-director of admissions, and she has been appointed the COVID safety czar for the School of Dentistry. What a title. Anyway, she has 9 years of clinical experience in community-based dentistry. Our third presenter is Dr. Darren Chamberlain, who is our immediate past president of the Utah Dental Association. We're glad to have him with us. He too is a practicing pediatric dentist and has practices in both Springville and Payson. And so without further ado, let me turn the time over to Dr. Bekker.
Thank you, Gerald. It's wonderful to be with everyone tonight. The level of professionalism and the quality of the dental profession throughout the state of Utah has always been some of the best in the nation. And tonight we hope that our discussion will help us to go forward in maintaining that as we do dentistry in a whole new world. I am going to share my screen at this point, and hopefully you'll all be able to see what we want to talk about. Gerald, can you give me a heads up, or Alex, is that screen visible?
Yes, you're good to go.
Okay. So everyone, I thought about this, and we're all talking about going forward to the future, and Back to the Future seemed appropriate to me because We want to go back to being able to provide dentistry, but we can't go back to how it was. We have to go back to the future, to the new normal. And I want to start tonight's discussion with a question. Where do you want to be? Where do we want to be? Now, some of you might think, I'd like to be on the east side of Oahu, looking at the gentle breeze of the palm trees. I took this picture last year, and I have to admit, there are many times that I wish I were there. But in reality, that's not where we want to be. We want to be moving forward in our practices and accomplishing the objectives of providing excellent care. So tonight, we'll go, as Dr. Bozeman mentioned, we have some things that we want to share with you. And they are outlined as follows. First and foremost has got to be the safety of our patients. As we are providing care in this new environment, we have to ensure that everything we do not only helps to heal, but does not cause any compromise to our patients, and that all of our practices, areas where we practice, are not ever sites for the spread of disease, specifically the virus. So patient safety, number one. Number two, in that environment, we need to talk about how to provide excellent care and what that means. We can't compromise our care just because we have a few more hoops to jump through or some obstacles to overcome. I think it's our responsibility to counter the negative and fearful media input about dental visits. And you all know what I'm talking about. There are reports in various media platforms that are warning people not to go to the dentist. It's one of the most dangerous places for the spread of the virus. And as the dental school, as we are starting and beginning to see patients, this is one of the biggest questions that we receive is questions about all these negative reports that they've heard about. We need to be well informed so that we can help people understand that it is safe and that they can be treated safely. Communication with patients is absolutely essential. And we'll talk about that, because it doesn't matter how much you go through to get your office ready and to be prepared and to be safe. If your patients don't know that, then you won't be able to provide the excellent care. And I think sometimes we go back to the way it used to be, and we don't realize we've got to do extra communication in today's world to help our patients. So with that, we're going to turn the time over to Dr. Chamberlain to talk about the American Dental Association and the Center for Disease Control guidelines. Dr. Chamberlain.
Thank you, Jim. Appreciate it. Let's see if I can share my screen here.
Dr. Bekker, go ahead and stop screen sharing.
Okay. And I do that right up here.
Alex, can you see my screen now?
Yep, looks good.
Wonderful. Yes, as Dr. Bekker and Jeri Bozeman said, my name is Darren Chamberlain. I'm the past president, immediate past president of the Utah Dental Association, practicing pediatric dentist, and have had, I guess, since I'm on this, the UDA felt like I was I don't know if I'm the best person to address this, but they put me out here because we've dealt a lot with COVID-19 in the last few months. I'm just going to do a quick review. It seems like forever ago that Rudy Gobert was tested positive for COVID-19, but that was just March 11th, and less than 3 months ago. Less than a week after that, the ADA recommended that we see only emergent and urgent care patients. very shortly after that, the Utah Department of Health mandated that we postpone all elective surgeries in the state. And much to my dismay, the UDA convention was canceled. At that point, I was supposed to have stepped down as the UDA president, and Mike Schmuen was supposed to have taken that role. And unfortunately, I continued through the COVID crisis as the UDA president, and we had a fun experience through this. March 27th, Governor Herbert issued the Stay Safe, Stay Home directive, and April 17th, they came out with the guidelines for what we now know as the red, orange, yellow, and green regulations in the state. A day before that happened, I had an interesting phone call come in very late at night from the task force of the Utah Recovery Task Force for COVID-19, asking what the Dental Association felt should be the guidelines for that. And fortunately, earlier that day, we'd had a conversation with our UDA Recovery Task Force that included individuals from the U of U and Roseman Dental Schools, along with the Utah Department of Health and various other entities. And we had come up with some guidelines, and I quickly emailed the individual that was questioning and gave them the interim guidelines that we had received from Elizabeth Shapiro at the American Dental Association and their recovery task force. When we originally saw the guidelines, it looked like dentistry would not be allowed until we hit the green level in the state. And it was very disconcerting when these original guidelines came out. Luckily, they took what the UDA submitted and applied those for all medical elective surgeries, including dentistry. And so the guidelines that you now see in the state were submitted directly from the Utah Dental Association. We're proud of that fact. In fact, Governor Gary Herbert on April 21st, in a letter, thanked the Utah Dental Association for their involvement with the guidelines, and they considered dentistry an essential business, and we're very glad for that. So on April 22nd, we in Utah were the very first state in the country to start elective dental procedures again, and we're glad for that point. May 1st, we moved from red to orange. May 16th, we moved from orange to yellow. For most of the state, there were a few counties and cities that were not, and now I believe we're pretty well there. And we're looking forward to the next step. Hopefully green is very soon. The UDA helped quite extensively in this, and you can see on this slide, we've had regular communications with a lot of the practicing dentists in the state. We've answered emails and texts and phone calls, and we appreciate those on the staff that have really put a lot of time and effort into this, including Dottie and Becky and Val Radmal. We communicated with the governor's office, the Utah Department of Health, the COVID task force, ADA leadership, the president-elect and executive directors of the surrounding states, the ADA's health policy, the HPI Health Policy Institute, DOPL, and the dental Medicaid insurance companies. And we've procured face shields, KN95 masks, and surgical gowns, other PPEs for practicing dentists. In fact, Val, I think, sent out an email earlier this week about 200,000 KN95 masks and surgical gowns that are available at your local Department of Health, and you can access that information from the UDA website. We've advocated for changes in teledentistry, and we've petitioned insurance companies to reimburse for increased PPEs, including a D1999 code. And I believe right now Select Health is reimbursing for that code, and there's hopefully a few other insurances that will come along with that. And I know Jim Bekker is going to go through some of this information, so I'm going to quickly just talk about the state requirements. Practices can reopen, but there's some precautions that need to be available, including make sure that we've got access to adequate PPE, and patients are encouraged to wear face masks. And in fact, anyone that comes into the offices are encouraged that way. ensure that we have a 6-foot physical distance between patients at all times, no congregating in waiting rooms. We ask that patients wait in their car, and then be escorted into the treatment room directly. Children play areas, toys, magazines, and those kind of items should be removed from the waiting rooms. And we ask to screen patients with a questionnaire, taking patients' temperatures, and only one adult may accompany each child. And we've encouraged them to wait outside in the exam room if aerosols will be generated. And then we have asked that plexiglass barriers, I guess the state has asked that plexiglass barriers be installed, or face shields to protect the front desk. And then appropriate PPEs should be worn when taking care of non-COVID-19 patients. And then this is an important thing, appropriate protocols by setting should be put in place for using appropriate PPE for those that are screened positive for having COVID-19. Now, we appreciate what the University of Utah has done. They actually have adequate facilities to be able to treat those patients that may have an emergency and are COVID-19 positive. And we would recommend actually that dentists in the state refer those patients up to the University of Utah. And I hope that the later lectures will talk about that. One thing that the ADA has done is given us a return to work interim guidance toolkit. This has been downloaded over 100,000 times. And if you look at the statistics, the vast majority of dentists have downloaded this toolkit. If you haven't seen it, I won't share my screen, but it is on the very top of the ADA's website, ada.org. And it has a welcome back reassurance sample letter that we can send to our patients. It reassures the patients of our commitment in the office to maintaining up-to-date infection control. It also goes through a pre-appointment screening process, explaining how to screen patients for symptoms of COVID-19 before the appointment and upon arrival. And then it gives an in-office patient registration procedures for dental teams to implement at the front desk, and the reception area preparation strategies. And those are some of the things we've already gone over. In fact, you'll notice that the guidelines that the state has invoked are very, very similar to what the ADA has incorporated into this interim guidance toolkit. And that we appreciate the ADA giving us a pre-screen of that. And then staff protection strategies includes recommendations for in-office clothing, pregnant staff, daily COVID-19 screening, login for office staff. They do recommend that all the staff that comes in have a log in, and that they have their temperature taken at that point. And any staff that is over, I've heard two conflicting, anyway, anyone over 100 degrees temperature is asked to not work during that day. For patients, the number, and this is directly from the CDC, is 100.3. Anyone over 100.3 would be asked to not be seen in our offices. And then there's a shopping list of things that are important as we move ahead. They've recently put out this COVID-19 hazard assessment. You can go through and kind of look at this, and it gives kind of a step-by-step consideration for you can see a green, yellow, and red. Yellow being a caution, red being please don't start seeing patients in this environment. And you can access this again on the ADA's website. They have, for coronavirus, a specific webpage that has access to all of this information. And you can see that there's some recommendations, including a HEPA filtration system, and some airflow. Using a rubber dam is highly encouraged, and high velocity suction being used for all procedures that would generate aerosols. They also have on that website a page of what to do if someone in your staff tests positive for COVID-19. And you can see there are step-by-step instructions on what we need to do in the office if somebody does contract the virus. including questions. When was the last date of contact? How long was the contact? Approximate distance of the contact, and then how to send them to testing, and an idea of how long to quarantine if they need to. And there's also, I didn't include this, but there's steps to take if a patient reports COVID-19 exposure after treatment. And it's very important that we call the patient after the treatment is ended, so that we have a communication. I think Jim Bekker is exactly right, Dr. Bekker, that we do need to make sure that we have that communication with our patients so that we know if there is an exposure, and then the ADA has given us some guidelines there. And some of those guidelines depend on if the exposure is a high risk of exposure, or if there's a low risk if there was minimal contact with that patient, and they go through steps that way. The CDC guidelines are actually very similar to what the ADA guidelines were, and it's almost like we were waiting a long time for the CDC to come out with their guidelines, and the ADA said, you know what, we can't wait any longer. We're going to come out with our own guidelines. And I think the CDC said, you know what, let's just take those guidelines that the ADA recommended, and we'll move ahead. And so they very much reinforce what the ADA guidelines are. One thing that the CDC recommends that's not included in the ADA toolkit is allowing 15 minutes between patient leaving the operatory and cleaning the room. And this allows droplets to settle on hard surfaces, and then it's easier to get in and clean that room. I just listened to the latest CDC webinar, and they admitted that there's no scientific basis behind this recommendation. However, they thought that it is the best practice. And so for right now, that's kind of the recommendation. And so if we can be patient and wait just a little while for things to kind of settle down in the operatory, and then go in and wipe down that operatory is kind of the main recommendation. One other thing that the CDC had talked about was HEPA filtration systems, and the HEPA stands for high efficiency particulate air, and these effectively capture 99.97% of droplets that are released into the air. HEPA filters capture particles larger than 0.3 microns. Now, the novel coronavirus is 0.125 microns, and so you think, how is this effective against those kind of, well, this virus? And the actual studies show that the novel coronavirus is not isolated. It's always contained in a droplet, and those droplets that contain the coronavirus are 1 micron. And so this HEPA filtration system is very adequate on capturing these droplets and disposing of them. One thing that they did say is make sure that HEPA filter is placed in an operatory in a location that the particles are not drawn past the operator or the assistant. So if you look in this, oh, we've got to go back. Sorry, I jumped the gun there. If you look in the picture of this operatory here, this HEPA filter is in the corner, and hopefully it would not be wise to put it on the side where either the dentist is operating or the assistant is located, but maybe somewhere where it's away. And the best place is actually the foot of the chair or at the head of the chair, just to be able to isolate those droplets and not, again, draw them right past the operator or the assistant. And that's, you saw my next slide. That is the end of my presentation. And I'm sure that if there are any questions, feel free to ask at the end. And you know, anything that we can do to prevent this virus from spreading to the public and protect our staff is very, very important. And the UDA is very committed to making sure that we are practicing dentistry safely in our practices. And I will turn the time over to our next speaker. Thank you.
I'm Dr. Jeri Bullock, and I'm going to share my screen here. Let me get that up and going. Okay. And Alex, are we good to go with that?
Looks good.
Okay. Well, thank you for joining us this evening. And I'm going to talk a little bit about the School of Dentistry's new normal with COVID-19. And if you have a QR reader on your phone, please get that out. I have a number of resources that you'll be able to snap off your QR. So get those ready for a little bit later. So the safety philosophy that we took at the School of Dentistry was to act as if you are COVID-19 carrier and everyone around you is a COVID-19 carrier. If we act and think in this manner, we're able to produce safety protocol and measures that minimize the risk for transfer of COVID-19 as much as possible. The safety goals that we work under is to protect our patients from healthcare workers and other patients, to protect healthcare workers from patients and other healthcare workers. And the worst thing that could happen is if somebody who was in the dental office transferred COVID-19 or brought it into work with them. So our safety goals are centered around protecting everyone within the office. So what's our new normal? Pre-procedural testing, universal masking, and augmented PPE. So let's talk a little bit about pre-procedural testing. And I don't know if anybody has had the pleasure of getting this done, but this gentleman is certainly handling it a little better than I do. Our providers, staff, and clinic personnel are tested every 2 weeks for COVID-19. And this ensures not only an extra level of protection for them, but it also sets the stage for additional research that we'll be conducting at the University of Utah that we hope can have a huge impact on the dental community as a whole. So why the pre-procedural testing? Well, research shows individuals can be infectious up to 2 days before symptoms begin, and some may not develop symptoms at all. So we just don't know who has it and who doesn't. We're utilizing student dentists as providers, and we want to ensure the safest possible learning environment for them. And the clinic facility in which we work is an open bay facility. This allows aerosols to travel between operatories at a greater rate. So when patients are scheduled for the School of Dentistry, first they're screened to ensure that they do not have COVID symptoms, and they need an urgent or low or no aerosol dental procedure. Then an order is placed by the provider in the electronic health record, and the patients receive the test at any of the UView health testing sites. The results are typically received between 24 and 48 hours. And a negative result, the patient can proceed to the dental treatment. But a positive result would cause delay in treatment until the symptoms or a COVID negative test occurred, or we would send them to the university hospital's negative pressure room. So that's operated by our general practice residency, like Dr. had mentioned before, that we do have two negative pressure rooms in which to see COVID positive patients with. And then patients are treated within 3 days of the test. So we want to ensure that that test is as accurate as possible for a negative result, and that the patient has a minimum environmental exposure between the test date and the treatment date as possible. But testing is not 100% foolproof. PCR testing for asymptomatic carriers is only between 50 and 70% sensitive across the nation. So that means false negatives are likely with asymptomatic COVID carriers. And PCR testing may not pick up COVID carriers who are in their incubation period. So those who have not developed symptoms can still shed the virus, and that would be termed the incubation period. Our testing challenges that we've ran into is that patients are not 100% compliant. We've screened them, we've scheduled them for appointments, but for one reason or another, they don't get tested. And that could be due to transportation issues, a proximity to the U Health Testing Center. We don't have testing centers everywhere, or there is a fear of the test itself. The timing of the test can also be difficult. Like I mentioned, we try to test and then treat within 3 days. But we ran into issues over holiday weekends like Memorial Day. And then we also had testing delays with the protest and rioting curfews. So we'll move into universal masking. Why should we wear face masks? Well, if we think of coughing and sneezing in terms of urinating, and if we all walk around naked and someone pees on you, you get wet right away. But if you're wearing pants and someone pees, the pee will get through, but not as much, so you're better protected. But if the guy who pees also is wearing pants, the pee stays on them and you don't get wet. So masking is there to protect you from other people from you, and it benefits everyone all the way around. So that is why universal masking is encouraged and required at the University of Utah. Providers, staff, students, and employees are expected to wear facial coverings to and from work. They are required to wear a procedural mask while in clinical areas and around other healthcare workers. Patients and visitors are required to wear facial coverings when in the building, except during treatment procedures. And if they do not bring their own, a level 1 surgical mask is provided for them at the COVID screening stations. There are some challenges with universal masking. Again, compliance is not 100% all the time. We find faculty, staff, and personnel get relaxed off the clinical areas and don't wear the mask 100% of the time. Break room and eating areas are high-risk areas. Disinfect the table before and after use, stagger lunch break times, or encourage them to take their lunch outside. These face masks are really cool, and I guess you could buy them for all your staff, and then we do have a higher surgical mask burn rate, so it's something we really watch closely to ensure that our PPE levels and restock levels remain sustainable. So let's talk some augmented PPE. So the OSHA's exposure risk levels associated with dentistry, the School of Dentistry is working under medium and high risk levels. So high risk because we are performing aerosol generating procedures on well patients. And it's good to note that OSHA does require a NIOSH approved N95 or higher respirator mask for all aerosol generating procedures, even on well patients. So respirator masks are used for direct patient care. You can see the students here are in their PAPRs. So it's a personalized air, and I can't remember the full acronym for it, but they have these little battery packs that pumps air into their hoods. And these students actually failed the fit test for an N95 and KN95, and that's why they require the PAPRs. Other students and faculty and personnel wear N95s and KN95s with a level 2 surgical mask over the top to protect from large droplet particles. These masks, the respirator masks, are reused by that single user, and we have sterilization through the university hospital for reprocessing them. A level 3 surgical mask is used for indirect patient care, like sterilization. Augmented PPE challenges. As we talked about already, there's limited availability of N95s and KN95s masks. Fit testing is time consuming. We have a large number of employees, personnel, and providers that come through the School of Dentistry, so fit testing is ongoing for us. And fit testing for the respirator mask must be done anytime a wearer changes the style of mask. So if you've been shopping for N95s and KN95s, I'm sure you've noticed there's various styles of them. And anytime you switch the style, you do need to perform a new fit test. And then compliance can be difficult. Wearing a respirator mask, it is more difficult to breathe, and you need to watch people's oxygen saturation levels because they may drop. If personnel are getting lightheaded, dizzy while wearing the respirator mask, please take them off the clinic and get them some oxygen, take the mask off, and let them recover. We also have challenges with facial hair. Facial hair can interfere with the seal of an N95 or KN95, and I have a QR code here for you. This is the CDC's recommendation for facial hair to wear a respirator mask. It's a good picture diagram, and it has worked well for us to give good guidance for those who like to wear facial hair. In our overcoming the challenges, we have continuous training. So we're always training our staff, particularly on donning and doffing of the PPE, to ensure that they're not self-contaminating. We have overt communication regarding safety expectations. We have weekly emails that go out regarding safety, and then also our dean has a weekly Zoom call, and safety is always mentioned in that as well. We have our designated safety czar. Myself and one other individual are safety czars, and we maximize the safety, we monitor safety, and it's a higher level of oversight for that. We also established a fit testing team. As I mentioned before, we do a lot of fit testing, and we needed to identify specific staff members to constantly be doing that fit testing, and we even designated a particular room to make that happen. So the new and better normal for the dental patient. So CBS News reported from a survey that 71% of respondents were uncomfortable going to the dentist during the pandemic for non-time sensitive procedures. So how do we keep our patients comfortable during dentistry? Communication is key. Communication can be sent via mail, email. Phone scripting is really important. It's used to ensure a consistent message is always delivered to the patient. This is an example of the communication that we send to our patients. So it talks about, we're safe, we're open, we're here to care for you, and here are the safety steps that we're taking. Our providers are tested, their daily temperature screening and health reviews, and then what we're doing for the patients, that higher level of safety for the patients, then just the overall building safety. The new and better normal for the dental staff. Again, overt communication regarding safety expectations and protocols. They want to know what's going on. They want to be part of that conversation. Universal masking. They need to understand why that's important and how it protects them. Same with the augmented PPE. They have to know how to use it, when to use it, and know that it's protecting them correctly. And then the continuous safety training. I would recommend designating a safety czar. whether that's yourself or another staff member. And then I'd also recommend this course. It's an online course through Coursera. It's offered by Johns Hopkins University. They review everything about the COVID-19 virus, from the virus itself to contact tracing to PPE. It's all within that course. It's a great course to take. I highly recommend it. And if you missed the CDC COCA call that was earlier this week, I also recommend listening to that. Again, it covers PPE, when to open your office, HVAC systems, and I think Dr. Chamberlain mentioned that as well. And feel free to reach out to me. You can email me. Again, that QR code will link you right to my email. You can utilize me as a resource. I'm happy to help and share any way that I can. And I'll pass it over to Dr. Bekker. Dr. Bekker, you're muted.
Thank you. Dr. Bullock and Dr. Chamberlain, thank you so much for all of that insight. I've enjoyed seeing the leadership that's come from the Utah Dental Association, and especially appreciated Dr. Bullock's oversight for safety at the school. I'm going to try and share my screen now again and just make some conclusions. We want there to be time for questions and answers. So I'll go through this next part a little bit quickly. We all know there are levels of care. And when everything shut down, we went from green to red very, very quickly. We've gone now from red to orange, and in many places we are going from orange to yellow. The best practices in going back to treating patients are optimally achieved if we begin treatment in this new environment in stages. That means we've got to take it step by step, take it slowly. We've got to allow our staff and the providers in our office to learn the protocols and beware of falling into old habits. It's very tempting to go back to how we used to do it, but we cannot go back. We've got to go forward to this new and better normal. Learn what procedures require extra caution and how some procedures should be initially avoided. And then think of everything with aerosolization. I think that slide Dr. Bullock put up of the man coughing, I'll have nightmares about that. Think of aerosolization and things we do that will cause particles to go into the air. Now, this is the chart that we've followed at the University of Utah. We review it for your information. All of you are working in different settings and different offices. Let's just look quickly. The green level says routine, elective, and emergency dental care using standard universal precaution PPE and surface management with routine operatory spacing. Patients screened for COVID risk by temperature, symptoms, and initial presentation at all subsequent appointments. And then those who are suspected to be positive would not be treated. That's the green that we are headed back towards. That's where we want to be. But it isn't the normal that we are used to. And we've got to remember that we will always be screening patients, taking temperatures, using PPE as we move towards this new normal. The yellow is with augmented PPE, and Dr. Bullock has talked about that with the masks and all the things that we do. We are doing in our yellow. Well, we're currently still on orange. As we move to yellow, we will still be doing the testing. The difference between orange and yellow is that in the orange area, it's only elective or only care that is done where if it is left undone, the patient would, the condition would get worse. And so that elective care is only provided when there's a significant risk of increased morbidity. Yellow will be all the procedures that we need to do in dentistry, but with much heightened caution, PPE, and protocols. So as we look at these different levels, I want to just share with you, moving towards a new normal, you evaluate what procedures are safe and recommended at each level of your office. You may want to look at the procedures that you do and kind of categorize them into which level they require. Evaluate what changes you need to make in the physical office setup that you are currently using. And I'll just share this chart with you, and you might even want to take a screenshot of this. This is what we've done at the university, where we, if you look in the gray columns, that's the department. And then the green tells us in that department what is allowed under our current restrictions, and what is not allowed is listed in the yellow. And for instance, we can go to restorative. It's the fourth box down on the left. Sedative fillings without handpiece or air water spray use. And so when you're in an orange category, you can't generate aerosols. And so we do sedative fillings without air water spray use. If you look over, if you look at periodontics, we can do scaling and root planing, full mouth debridement, local delivery of an antimicrobial, periodontal maintenance, and scaling in the presence of gingival inflammation, adult and children prophies, and coronal polishing. What we can't do is use of an ultrasonic or an air water spray combination. So that's just an example of how we've gone to each of the areas of the care that we give, and we've categorized them as to what we can do and we can't do. That would be a good exercise for you to do in your offices as you evaluate those procedures. Communication with patient is the key, and I'll just end on this. Before the visit, have your staff reassure the patients that your office is a safe place for treatment. Explain the protocols to the patients. We're going to limit the number of people that come with the patient, and they'll wait outside in their car or outside somewhere until they're called by the front desk when you're ready to see them. Dr. Chamberlain reviewed that. And then ask them to bring their own mask. It gets very hard to provide masks for all your patients. During the visit, take their temperature when they come and ask the appropriate screening questions when they arrive. Anyone with symptoms should not be treated, but will be sent for COVID-19 testing. Treatment areas, all of your treatment areas need to have consideration for appropriate distancing, and this applies to the waiting room, the check-in and check-out areas, and especially the patient treatment areas. And of course, as Dr. Bullock has stressed, appropriate PPE throughout. After the visit, and I can't stress this enough, a follow-up call is very important. This shows that your office genuinely cares about them. And some will say, well, this is cumbersome in a busy practice, but it can be done if you're organized and you use members of your staff effectively to call patients. And calling 3 or 4 days after the visit should be considered to make sure that there have not been any COVID-19 symptoms that have developed, as Dr. Bullock stressed. So communication before, during, and after your visits is extremely important. Remember, we're not going back to how we practiced dentistry just a few months ago. We are going forward to a new normal that is a higher and safer level of treatment. It's our responsibility as professionals to provide excellent care in a new and safe environment. We've really enjoyed this discussion with you tonight. Here is my contact information, and I welcome any questions if you would like to email me about anything you have from the presentation, or Dr. Bullock or Dr. Chamberlain tonight. Now, Alex, during this time, has been looking at the questions And I think he can moderate a discussion where we can have you answer questions and see what we can do to answer some of those questions. Alex?
Thanks, Dr. Bekker. So far, we've only actually had one question. So if people have more questions, please submit those in the Q&A at the bottom of your screen. The question that I have says, is there a quiz after for people to get their CE credit?
I can answer that. Am I on?
Yes.
We can hear you.
Okay. To clarify, what you need to do to get your CE is just by having registered and logged on to the Zoom webinar, that's evidence enough that you attended. So those who logged on and attended will tomorrow in your email receive a CE certificate from the U of U for 1 hour of CE. And you will also receive a survey that can be completed online and just sent back. And we would encourage you to complete those and send them back. It's extremely helpful for us. So that's the CE for those who attended. Those who want to view the webinar that's been recorded and want to receive CE credit for that, they need to contact me at the University of Utah, and we will set that up. And in that situation, there will be a 5-question quiz before you get your CE certificate. So contact me, gerald.bozeman@hsc.utah.edu. And I don't expect you to remember that, so just call the U and ask for me and they'll get you through. So I'll go ahead, and if there's any other questions, we can answer those first and then we'll wrap it up.
Thanks, Dr. Bozeman. Yeah, the floodgates just got opened, so I'll try and go through these quickly. This first one will be for you. Have you explored the use of custom frames designed cheaply using facial recognition features on iPhones, which, when used with a surgical mask, are testing as well as N95 masks?
So
That
I
question,
can take.
go ahead.
Oh, go ahead, Dr. Bozeman.
No, go ahead.
Oh. So I know our Center for Medical Innovation has been looking at those, and so far we haven't gotten them approved through the U Health system, but Dr. Bozeman, do you have more information?
No, I don't. I was going to defer to you.
Okay.
All right. The next question is, someone asks about our table for doing certain procedures versus not doing certain procedures. Salt Lake seems to be more restrictive than other areas, such as ultrasonics. Do you have a comment about that?
Yes, I believe that's from Dr. Jessup. It's good to have you join us tonight. It's good to look at the level of your community, and Salt Lake is still on orange. Many communities in the state are on yellow, and that's a kind of a good guide, but it's also very important to stick to what the ADA is recommending. And every office has got to look at their specific situation and the surrounding and the type of patients and the situation, and make that determination for what level you will be at. We would encourage erring on the side of being very, very careful.
Dr. Bullock, someone asks if there's a way to do fit checking for staff at offices.
It's something that we may want to explore, and maybe I can work with Dr. Bekker on that. If you're interested, if there's high interest through our UDA members, we might be able to partner with them. Just send me an email or Dr. Bekker an email, and we can try and work on that.
Yeah, we might even be able to do a little segment showing how to do a fit test.
Okay. Have any of the panelists heard of a confirmed transmission of COVID-19 in the dental office?
I just had a communication with the leadership of the UDA last weekend, asked this question, and there had not been any reports, at least from the UDA's perspective. So we have not heard of any. If anyone does have any examples of that, if you would contact the UDA office, that would be very appreciated. But we have not heard of anyone in the state contact or contracting the COVID-19 virus.
Thanks, Dr. Chamberlain. Someone asks if pre-procedural rinsing is recommended.
I think there are mixed scientific reviews on that, but we would say yes, it is certainly doesn't hurt and it can help. I think Gerald could address that a little bit. One of the things we didn't cover in our presentation as much is, again, as Dr. Chamberlain said, use of a rubber dam and high volume suction to really keep that aerosolization down. Dr. Bozeman, what have you learned about the pre-rinse?
Again, that's one of those areas, I think, when we get advice from different entities, it's conflicting, and I don't know the scientific evidence. I agree with you that it doesn't hurt, it could only help, and so I'm not sure who's recommending it, but it's certainly something to consider.
Okay.
I just saw some research on that they're looking into chlorhexidine and have some promising preliminary results as well. So both chlorhexidine and
Hydrogen peroxide.
Hydrogen peroxide, it looked like they're as promising as anything right now.
Okay. Do we know how many times an N95 or KN95 mask can be steam sterilized and remain effective?
Yes, so
But ease on it.
so the KN95 or an N95 can be donned and doffed 5 times. So put on and taken off 5 times, and then it needs to be reprocessed or sterilized. And that process can happen 5 times as well, or until the fit is no longer sealed or there's damage to the head straps or ear loops. So potentially you could get 25 donning and doffings out of one mask if you're wearing a cover surgical mask over the top of it. And that is the procedures that we're going by.
In response to the last question, someone writes that chlorhexidine is not as good as hydrogen peroxide or iodine. Gordon and Rella Christensen say, please don't think that chlorhexidine is an option. So I just wanted to make sure that that was told to the group.
The research I saw was, I believe the CDC was looking into it. So and that was as of yesterday. So that's the unfortunate thing about this is we don't know quite yet. And we're all trying to figure this out. And hopefully with the new research, we will see some promising ways of practicing and the standard of, I think Dr. Bekker is exactly right. The standard of care has maybe changed a little bit. And at the end of this, hopefully we will see the best practices, but there's some question marks right now for sure.
Someone asks, if a surgical mask was adequate for AIDS prevention, why is it not now? And then for the U of U faculty in the room, they ask if the U is using HEPA filters for the clinic.
So the reason why we need the respirator mask is because this is a respiratory virus. So it is transferred through the salivary droplet particles or respiratory particles versus the AIDS virus, which is transferred through different means. So just breathing in the respiratory particles can infect you with this virus. So that's why the need for the augmented PPE beyond the surgical mask. And then the HEPA filter, Dr. Bekker, do you want to take that?
Sure. We have the HEPA filters at the University of Utah in the general practice residency clinic that are helping us have the ability to treat even COVID positive patients. And that's where we see emergencies, so that if we're unsure, if there's any question, they're seen there. We don't currently have HEPA filters in our open clinic at the University of Utah. We are only seeing 10 patients in a session right now in a clinic that holds 62 operatories. And so they're extremely well distanced. at this point. And again, it's early days for us. It's the beginning stages of evaluating, and we may be going to HEPA filters. That's part of all of this research that we're doing to see what the best practice will be.
Someone comments that they recommend to instruct to patients not to take Tylenol or ibuprofen the day before their appointment, as it can lower their temperature and give you a false temperature reading. And then another question is, are you exploring alternative testing methodologies like saliva or tongue scraping that might be less objectionable and possibly more accurate?
So I can
go ahead, Dr. Bekker. No, go ahead.
Oh, I can just tell you that when I was tested earlier this week and she was about to tickle my brain with that Q-tip, I asked if they were working on the saliva test, and they are doing those tests right now. At one of the U clinics, they're testing the saliva swab. We're hearing that the turnaround time is a little bit longer, and so they're working on getting that, and we fully anticipate that we'll be moving towards that at some point, hopefully sooner rather than later. Dr. Bullock?
Yeah, and I was just going to mention as well that same thing, but also we have a virologist who is working on a salivary test as well to test for patients to become reinfected. So they've recovered from COVID. Are they susceptible to getting the COVID virus reactivated? So we are doing some research on that as well.
The last question that I've got is, have other dental schools opened yet?
That's an excellent question. We've been trying to keep track of that across the country, and from what we can tell, immediately when we stopped operations in March, we closed our building off, and we kept it very COVID-free, and we've divided the building into 3 levels with a lot of precautions for who goes into which doors and which levels. Dr. Bullock has been great with that. Because of that, we're one of the first schools in the country that has gone back to treating patients. I do know Roseman is treating patients, and a number of schools are starting up. I don't know what the number is across the country, but I do know that we were one of the first because we maintained a COVID-free environment.
All right, and those are all the questions that have come in. Dr. Bozeman, I'll turn the time over to you.
Yes, thank you. We're out of time and we'd like to wrap things up. So let me just mention a couple of things. We already talked about the CE certificates being mailed out tomorrow to those who were online this evening. I'd like to sincerely thank our presenters tonight. They put a lot of time and effort trying to put this presentation together with the most up-to-date information that they could obtain. Hopefully this time together has been valuable for each of us and will be helpful in assisting us get back in practice. I want to put in a quick plug for our continuing education here at the U. Most of you should have by now received a folded up version of this, which is our CE program for the academic year. Our first CE will be on September 11th, a memorable day, but that will be Dr. John Coyce. I don't know if I can get this where you can see it. So put it on your calendar. We're in the process of making the decision whether it will be live, virtual, or a combination of the two, but no matter what, it will be a valuable time spent with Dr. Coyce. We also are planning to, as we get more experience with virtual online webinars and recorded CE, we're hoping to offer more of that to our professional community here, both dentists and hygienists. So if you registered tonight, we will send you information when those opportunities come available. And lastly, I think that's it. So we've covered most everything. So thank you for joining us tonight. Sorry we went a little bit over time, but I think those were great questions, and thank you to our panelists for answering those. So thank you and good night.
Thank you all. Good luck in moving forward.